Now I would like to give a floor to Dr. I.Rykov. He is head of the oncology unit of the hospital 122, and he's a professor. His talk is Tumor of Pancreatic-Biliary System, Modern Trends in the Diagnosis and Treatment Algorithms, and View of Oncologists. Thank you for all those who are here. I understand that you're all tired, and I'm going to be as brief as possible. I have a very hard task, because actually everything has been already said. On the other hand, I would like to stress some issues which are important for medical oncologists, which is my field, but some things, of course, I would like to describe in more details. First of all, I'd like to say that we can say that there is one single disease developed in this area, in Pancreato-Biliary zone. There are lots of disorders in this area. They could be malignant, benign, and the most important issue is to differentiate them from one from another and to find timely to detect the diagnosis of interest. I would like to miss hepatocellular carcinoma because it's one of the most frequent pathologies in this area, and I would like to pay more attention to adenocarcinomas, which are most of the frequent tumors in the ducts and pancreas. To understand what we're talking about, I would like to show you some numbers which are actually terrible. That's the data of the American Oncologist Association, CCM, which are better than the Russian ones, but look at those numbers. You could see the stage distribution on detection of the tumors coming from the pancreas and the ducts. You see a bit better situation with cholangiobiliary carcinomas versus the pancreatic cancer, but it's not much better. As for contrasting, the breast cancer, the most frequent disease in women and the leading mortality cause, you see 60% of patients, they detected at early stage and only 5% at stage 4. And we see absolutely vice versa situation for pancreatic and cholangiobiliary cancers. Situation even worse with 5-year survival. You see stages 1, 2, the patients should live a lot, but not. Only 1/4 of the patients can survive the period of 5 years. We're talking about the 4th stage, then 5 years, almost none of them can survive it, both for pancreatic and ductal cancer, and the contrast, lung cancer. It is the biggest problem of oncology, the highest mortality, high incidence rate. It is stages 1 to 50% of, more than 50% of patients survive for 5 years, twice as much. The same we can say about the stage 3 and twice as much about the stage 4. It's fantastic. And we are talking about the lung cancer, breast cancer, and we don't pay attention to that pathology. This problem is discussed a lot, and I think you saw this photo. That's a so-called social ad, which was done in the UK about 6 months ago. It's a photo about the British Cancer Association, and it says, "I wish I had breast cancer." You see this young woman with advanced form of the pancreatic cancer. So both doctors and social workers tried to draw attention to this group of patients, so to help them to improve the care of them. What's the problem? Beside morphological locations and location of this tumor, it's hard to reach this place to do the biopsy. Of course, the breast gland is easier and closer. But the problem is that at early stage of this, usually we see nothing. We see no clinical signs. Patients don't come to us. They cannot palpate this tumor. Nothing disturbs them. So there are no complaints. So all the symptoms we're used to, they appear in case of large tumors like jaundice, stool change, pain, weight loss, appetite loss, and fatigue. It's usually a sign of the really advanced disease when we hardly can think of treating this patient. So we think about, so we suspect or diagnose even cholangiobiliary pancreatic cancer. So what should we do? First of all, as it was mentioned several times at the conference, first of all, we should stage the disease and the cause of the disease. So we should do CT and MRI with contrast enhancement and also do AUS. That's the basis to plan for the patient treatment. Without that, it is impossible to plan any treatment. Of course, of great value for us is biopsy. I would mention that later. And additionally, we should of course study tumor markers, which cannot be diagnostic criteria, but they are very important prognostically in a predictive sense when we plan the treatment. And besides, there's additional methods like PET combined with CT and laparoscopy. Of course, they could be of help for us, but the only thing we should remember is that PET, as we already mentioned today, it could give you false negative results if the tumor is quite small in size, which quite often the case in these patients. Less than 1 centimeter in size, then probability of detection is very low. If it is less than half a centimeter in size, then PET is useless. Laparoscopy in this situation help you to avoid large interventions like laparotomies with some negative consequences and find earlier distant metastasis. Why biopsy is important? If you're going to do something radical, then biopsy will be required later, and it will be the post-op biopsy. But if we plan any treatment, like neoadjuvant treatment, palliative treatment, or adjuvant treatment, then without biopsy, start treatment is prohibited. None of smart, no good oncologists would start treatment prior to morphological verification. Why? Because it means that we might treat something wrong. As adenocarcinoma is the most frequent tumors in this case, it doesn't provide very high survival rate, but there could be other tumors like lymphomas which you could treat without any surgery. We could really treat them. And if we diagnose the tumor properly, then we wouldn't, this patient wouldn't need any hospice. This patient could survive the treatment. So if the patient is inside, is doing the surgery, we're happy to say that it happens this day, you should do biopsy. 5-10 years ago, surgeons, they said, we opened up, we saw the metastasis. The surgeon said, you just do treatment. But today we understand that there is no general cancer disease. Cancer is a really diverse disease, and histology and pathological diagnosis, it's a basis to select further treatment, further patient management. I'd like to divide these also the two large groups. Let's start with the pancreatic cancer. So generally speaking, all our pancreatic cancer patients could be divided into two large groups. First, these are patients with resectable tumor, with borderline resectable tumors, and non-resectable disease. So resectability criteria are well known, and they define approach to such patients. In particular, if the patient is resectable, then the only way to cure this patient is the surgery, followed with adjuvant treatment, which is very important, because many they do forget that regretfully surgery, even radical surgery, is not always can cure our patients. With borderline resectable tumors, we can do surgery immediately or consider neoadjuvant treatment pre-op if we think that there was a high probability we consider that radical intervention is impossible. And in case of non-resectable patients, the main method of treatment is palliative care. Surgery could be, so we do chemotherapy, and surgery could be of a palliative type, like anastomosis, or cytoreduction intervention is not necessary because they worsen prognosis. Such patients, they live less than without any surgery. For resectability criteria, first of all, there should be no distant metastasis. That's a basis to think that the surgery is indicated. And two additional criteria: there should be no involvement of large vessels like portal vein, celiac trunk, portal vein, SMVs. For borderline resectability, there should be no metastasis, and involvement of vessels should be to that type that we could do R0 resection. Criteria actually is a bit different depending on clinical guidelines, but that's a general rule of thumb. For neoadjuvant treatment, if we understand, then potentially the situation is operable, but we have some doubts. There are several chemotherapy regimens. Regretfully, there are no standards because effectiveness of this treatment is about 30 to 40% at the most. Talking about monotherapy with gemcitabine, it's only 25%. That's why saying there are standards for pre-op chemotherapy in case of pancreatic cancer. Of course, there are no standards. It's individual's decision. There are studies in the States related to the use of chemo and radiation therapy. In Europe and Russia doesn't use because of the very high toxicity of this treatment. Though modern radiation therapy is really well developed science, but there is a concern on toxicity, and here we prefer pharmacotherapy to chemoradiation. Let's consider patient underwent surgery. Everything's fine. We did resection, no metastasis, but look at the numbers. Once again, I would like to remind you the numbers. Stage 1 or 2, only 1/4 of patients would survive through a quarter, through a 5-year margin, 5-year period. So we should, how can we improve our patients? What we have in our hands. There is an adjuvant therapy, which today slowly but became more or less standard. And it started when they used gemcitabine versus follow-up. They found out that in the gemcitabine group, a patient 5-year overall survival is twice as much of patients under just follow-up. Several of randomized trials confirming this picture. We cannot compare them because they were different inclusion criteria, but they provide a similar survival rate of 2.5 years. And all those trials just showed that combination of gemcitabine in as monotherapy or in combination is rather effective and improves the general results for our patients, general outcome. But if it is a non-resectable tumor, inoperable patients, should we treat them? We should say for sure that if we do not treat such patients, then the average survival is 3.5 months only. Of course, there is a group of patients who would live longer. There are patients who would live less. That's an average number, 3.5 months only. With gemcitabine appearance, situation improved a bit. In particular, we see duplication of survival rate, but it's not that much. If we compare it to the breast cancer, to the colon cancer, it's just a half a year. But again, it's better than 3.5 months. And what's important, chemotherapy in situation, it doesn't worsen the quality of life, but vice versa, it improves it. I mean, those patients who were given gemcitabine, they have a better quality of life versus those without this treatment. Several trials assessing combination of gemcitabine with other chemotherapeutics. They are a bit contradictory, and to say which regimen is preferable is impossible. Better data was obtained when, after 2 large trials. First is a Prodigy, very interesting trial, was assessed FOLFIRINOX regimen. It's a very potent regimen with 3 chemotherapeutics. It's rather toxic. In 20% of cases, we saw 3rd or 4th grade toxicity, but 11 months of overall survival rate, which is twice as much of gemcitabine monotherapy, which is very good. Moreover, in 6 months, looking at the quality of life, they found out that patients have a better quality of life versus patients with gemcitabine monotherapy. The only limit of this treatment, the only limitation, we should find really, so to say, well-spared patients, because patients, fragile patients, are not cannot be used to this scheme. Basically, these patients could be done with another form of gemcitabine plus nab-paclitaxel, good effect, and overall survival even is better compared to gemcitabine monotherapy, though nab-paclitaxel is not registered in Russia. Talking about the ductal cholangiobiliary cancer, it's much more complex thing, because we don't have much of the RCTs, and there are not that many of such patients. And talking about the considerable or large body of evidences, it's really hard to say. Okay, but arbitrarily we could look at all cholangiobiliary cancers as a gallbladder carcinomas, intrahepatic carcinomas, extrahepatic carcinomas, and generally speaking, it's a rather arbitrary division, because clinically situation is more or less the same, but those gallbladder cancer is more aggressive usually versus other forms. Plus, you can see its complication at early stage because its clinical signs usually coincide with considerably advanced tumor. Of course, the most important treatment option is surgery, but as we said, in these patients, surgery is a very extensive manipulation up to liver transplantation. And regretfully, such manipulations, they are not available to all patients, first of all. Second thing, they're not always possible, just because the disease is usually found when this manipulation is just not possible. And the third, from financial point of view, it's not always possible to do this intervention. Additional, we could use ablative techniques with various chemotherapies, radiofrequency ablation, stereotactic surgery. Of course, in addition to surgical methods, but it does not guarantee patient cure. And chemotherapy, of course, it's an important part of treating such patients. Usually, with chemotherapy in adjuvant mode, though there is not that much body of evidences, and for palliative treatment, we have much more of a data. What's important from the point of view of surgeon? Of course, we should find out if the surgery is radical. All the studies showed that if we did R0 resection, these patients have much better prognosis than R1 patients, and of course it's clear. And if we hope, and if there is a probability, for R1, maybe we shouldn't strive for R0. So maybe it makes sense to start with palliative treatment, because R1, it is a majority of patients who will relapse, who will progress, and who regretfully will die because of the disease. For adjuvant treatment, what we know, that's an extrapolation of the data, where patients with cholangiobiliary carcinomas were included. These are usually pancreatic tumors, and it was shown that after surgery, with T2 and higher tumors, fluoropyrimidines and their combinations, gemcitabine and their combinations could improve overall long-term overall survival. Talking about the palliative chemotherapy, we have more of data. There is an RCT data showing that chemotherapy makes sense, and the most important study is a UKBC 002 study, and it showed that gemcitabine plus cisplatin combination could improve survival rate in these patients up to 1 year. Gemcitabine monotherapy is also possible, but its results are worse, and we use it in cases if we understand that the patients, for some reason, will not stand combined chemotherapy. Also, there is discussions on replacing cisplatin to some other drugs like oxaliplatin, which is less toxic. Of course, there are some studies, target technology they developed, and there are several studies for the second phase where they assessed possibility of use of such target agents like EGF inhibitors, VEGF inhibitors. It's a second stage trials. Still, we cannot say that it really provides significant data, but one of the trials showed that the combination of the EGF inhibitor plus gemcitabine and irinotecan improves survival rate up to 12 months, a bit more than 12 months. That's actually everything we know about cholangenic adenocarcinoma. Then that's the issue of individual treatment and future perspectives. What's important? All those tumors require multidisciplinary approach. We do know that without good diagnosis, radiation, morphological, without surgical approach, and pharmacotherapy, our patients have no chance to be cured. We should use all the means we have to try to save those patients. Of course, we should think about the screening in these patients, because we do know that there are some predisposition factors like chronic inflammation, but there are no clear criteria when, in whom, and how to search for early stages. We still do not know. It's an issue for further studies. Also, we have great breakthroughs in oncology. For instance, you saw about breakthroughs in treatment of melanomas and lung cancers, and we heard about the effects which are interesting and wonders even me, like taking melanomas. They just disappear just while we're looking at them under the treatment, but But still, there is no breakthrough. We need new studies, clinical trials, comparing treatment effectiveness. And of course, modern standards should be modified to comply with the level of the medicine we have at the moment. And thank you for your attention. Thanks a lot. Any questions, please? Please pass the mic. Could you tell me, please, asymptomatic stone disease, cholelithiasis, and chances to provoke a cancer? So does it make sense to remove the gallbladder? Well, the publication says that any chronic inflammation, any form of inflammation, including Cholangiobiliary origin, of course, they're provocative with regard to cancer. The removal of stones and gallbladders on time, if it is important. Well, I cannot answer the question because, of course, I think it's in general it's important because acute issues with stones, even without cancer, it's a big issue for the patients. So I think it makes sense, of course. More questions? I'd like to make a comment because there was such a pessimistic picture about pancreatic cancer. I would like to say that in St. Petersburg is not that bad. St. Petersburg is quite a lucky city. We have a federal center here involved with providing combined treatment to the patients. And the combined treatment is a pre-op and post-op therapy. And we have more than 160 patients who underwent this treatment. And I'd like to say that if we look at the European guidelines, they state that the pancreatic cancer is a location where it is recommended, where for patients recommended to participate in clinical protocols because there is no generally approved regimen. Your statement, there is no breakthrough, well, it's not a modern approach, because if we look at the 10-year perspective in changes with treatment of breast cancer and pancreatic cancer results, because of course there is a breakthrough, because about 10 years ago, gemcitabine was used for the first time, and since those days, there is a trend to appearance of pharmacotherapy for pancreatic cancer. I mean, intraductal adenocarcinomas. And you should differentiate success in treatment of some tumors like neuroendocrine cancer, and we shouldn't forget about this successes in this respect. Today we have quite interesting data on Abraxane, as it's an apoptotic cell which I mentioned. And if you have such a problem, you can send to us. Regretfully, it's not my problems only. It's the problems are more or less similar in the whole world. But I would like to respond to yes. But I would like to finish up. Yes, of course. And thank you for a wonderful talk. But with the breast cancer, you're right. Things are quite nice. But I would like to say to our colleagues that for St. Petersburg there are some trends. Positive trends. We're involved in very progressive trials. So in St. Petersburg, the problem looks to be more positive than in general. It's a European Institute of Röntgen Radiology, and it's a very serious concern of problems. But what I said, I talked about the non-neuroendocrine carcinomas. There is lots of problems, lots of issues to be answered. For instance, the last ESMO, it was a big shock for everybody because it shows a theory for cancerogenesis for neuroendocrine carcinomas. It doesn't work because usually when we talk about the carcinogenesis, we mean mutation of the gene which launches some pathologic cascade. Then there appears a clone of tumor cells which undergo some evolution. But for neuroendocrine carcinoma, it's not the case. And gene methylation has a value, not mutation, which changes our understanding in general of the cancerogenesis and how they might develop. That's why here we're talking about adenocarcinomas, which should be mixed up. It's a different result, different perspectives. In the long term, talking about the bright perspectives for those patients, well, regretfully, the data from St. Petersburg, from other countries, say that generally speaking, those patients live shorter, much shorter than patients with breast cancer. And like patients with breast cancer, pertuzumab, additional 15 months of addition. With pancreatic cancer, there is no such results. No embolization, no radioactive ampullae, non-surgery, no other modern approaches produce such great results. Of course, there are some group of patients who lives better than others, but it doesn't. But this problem still exists. This problem is not related to a specific clinic. I mean, the more they use the methods, the more methods with, the more armamentarium we have, the better. I do agree with that. But to say that we have a breakthrough in this respect, well, now, regretfully, my opinion, there is no real breakthrough. But that might be an issue for further discussions. And Karina Leonidovna would like to say something. You quite clearly at the end claimed that at the moment there is no clear-cut approaches to screening of tumor disorders in a potentially malignant disorders. But we saw it when even it was our patients in operating room, and recommendations of European and American associations are different. Since we have a conference format, a disciplinary format, in the roundtable, I would like to ask you as a question about your point of view as an oncologist. How should we do screening? You should do MRCP once a year or every 6 months. Should we test for CA19-9? If yes, or then how often? I cannot give you. It's a great question, really bright. It's a bright question, so it's hard to give a clear-cut answer. You know, the sense of screening is that it should be available and affordable, so to say. And the ideal method, like MRI and the sonography, is not available to the entire population. That's why I say that we should select those groups of patients which should undergo screening. From my point of view, modern and the sonography could give you lots of good answers. Availability of biopsy, a possible verification, it's very important. But how often? It's a good question. My opinion is every 6 months. But again, these tumors, they develop quite rapidly. But how to do it right, I'm afraid I cannot give you a clear answer. Talking about the oncomarkers, CA19-9 could be of great help, especially if there is no jaundice, because the increase of CA19-9 without jaundice has a high probability of the link to the oncologist. It's not a specific marker. It could be any tumor of GI tract, but will be more targeted in looking at this patient. If CA19-9 remains high and jaundice was treated, was so to say cured successfully, then it means that we should look targetedly from the point of view of cancer. More points. More questions? Well, you know, I have a question. Sergey in his lecture said that adenocarcinomas are ductal and acinury. But when I talk about these are a bit different. But when I talk about the adenocarcinomas in general, for you as an oncologist, what it affects, what it influences, what you take into account when you see in the report that it's ductal or acinury adenocarcinoma. Well, mostly prognostic. We can take it into account, understanding what's going to happen with the patient. But regimen is the same. Yes, general treatment is the same. The prognosis might be a bit different. But why neoadjuvant treatment doesn't work? There is such a big trend. Almost everywhere we see T2 and up, we use neoadjuvant and positive neoadjuvant treatment. Again, here we say that only the group of borderline resectable tumors, meaning these are really well advanced tumors with invasion to the portal vein, to large vessels, to great vessels. Why there are no attempts to start neoadjuvant treatment at early stages? There are attempts. They attempted to. The problem is ineffectiveness. As I answered the question, the previous before the last question. So the general response for these tumors is not very high. For instance, with intestinal tumors, neoadjuvant treatment provides a response. In breast cancer also we see the response on neoadjuvant treatment. When you talk about the pancreatic cancer, cholangiobiliary tumors, regretfully, the effectiveness rate is about 25%. In other patients, in most of the patients, we see progress or stabilization, which doesn't make possible downstaging, or it doesn't make work of surgery easy. Could you tell me a couple of words about gamma knife victims? It's an alternative to the surgery. It's addition to the surgery from your point of view. It's a very interesting area, which for me looks very, very promising. And there are works showing that such an approach to treatment is not was an R1 resection. We can avoid big surgery, and it's good. And I think it's very important for those patients who couldn't tolerate large major surgery. We see such trends in lung cancer when in old patients the lung lesion is too small for cyber knife, and we cannot do major surgery because they're somatically very severe, but the radiosurgery could give very good results. So I think that's an area which would develop. And moreover, we have our clinical examples where this method showed that it's very, very effective. For instance, we have one of the patients of 73 years of age who progressed after the first line of treatment with a pancreatic cancer. The solitary metastasis in liver appeared. We gave her second line treatment. She responded it, and then after that, cyber knife actually destroyed the primary focus and metastasis. So the disease is stable without chemotherapy for 18 months already. It's a great case. It's a rare case. There are such opportunities, but we should understand where to use such opportunities.
Oncologist. I have one comment. I want to underline your vision. What you said is very important. The rule of local treatments according radiotherapy or radiosurgery will increase maybe in years. But right now, in selected tumors, for example, of the biliary tract, it's too toxic, even is in high doses with radiosurgery. There's ulceration, as you know. There are some evidence in our European community of radio-oncologists that maybe there's a good rule for radio chemotherapy post-operative, as you mentioned. So it's not that toxic anymore since few years, since we have the intensity modulation in our patients. And what you mentioned is totally correct, that the ablation, so the radiosurgery with CyberKnife for metastatic liver disease is very successful nowadays with local control rates of 95% in 2 years.
Thank you very much for your comments, and I think it could be a topic for discussion after presentation.